Hello everyone, my name is Leverette. I am a senior nursing student at Columbus State University in the RN to BSN program, and I will be presenting this information about alarm fatigue. The objectives of this presentation are to define alarm fatigue. We're going to discuss the ways that we can reduce harm associated with alarm fatigue, and discuss ways to reduce the incidence of having alarm fatigue in our workplace. So what is alarm fatigue? Alarm fatigue happens when we are overloaded with too much sound. So it reads here that alarm fatigue is a result of sensory overload. When we as nurses are exposed to too many alarms, it causes us to be desensitized and pretty much just ignore them. Think about how many alarms you hear in your daily area of work. Can you name a few? We have call bells, IV pumps, bed alarms, ECG monitors, ventilators, code blue, fire alarms, and oxygen sensors, and many more. In 2013, the Joint Commission took steps to make alarms safer by issuing this National Patient Safety Goal 06.01.01. It focused on the management of clinical alarms systems that have the most direct relationship to patient safety. Let's look at a case scenario. In this scenario, a 54-year-old man was admitted to the hospital with hypertension and diabetes and end-stage renal disease. He came in with chest pain and was placed on an observation unit with telemetry monitoring. He was diagnosed to have non-ST segment elevation myocardial infarction. So throughout the night, the nurses noticed that the patient's telemetry monitor continually alarmed, showing warnings of low voltage and asystole. The bedside nurse took multiple measures to check on the patient, assuring that he was okay. She also notified the physician, who also came in to check the patient to make sure that he was okay, and neither of them felt that there were any concerns. Later, the nurse went in to do vital signs, actually about 4 hours later, and noticed that the patient was unresponsive and cold. And despite the fact that they called a code blue, the patient did not survive and apparently had been dead for some time. Even though the cause of death was unclear, the providers felt that the patient had suffered a fatal arrhythmia related to his NSTEMI. So let's take a look at the problem. The biggest problem is the fact that the nurse decided to silence the alarm because it was continuously going off, and each time she checked the patient, he was okay. But silencing alarms should never happen, and it was found to be the biggest contributor to this patient's death. The correct action would have been to do a 12-lead EKG to assure that the patient's rate and rhythm were okay, and to look for alternate methods of monitoring this patient's ECG rhythm. So did you know that in a typical intensive care unit, there can be up to 400 alarms per patient, and over 80% of those alarms, especially the ECG monitor alarms, are usually found to be clinically insignificant. In 2011, the Boston Globe investigation identified that there were more than 200 deaths over a span of 5 years due to the failure of staff appropriately reacting to alarms. So what are the causes of alarm fatigue? The biggest reason is that we as staff get so tired of hearing alarms, especially those that are clinically insignificant, otherwise known as nuisance alarms. There's also many times a failure of the alarms to properly function. There's difficulty in discerning which alarms go where, which room, which patient, because so many alarms sound the same. We just get desensitized because we hear alarms day in and day out, especially on an inpatient unit, and we unfortunately tend to tune them out, even though it's not usually on purpose. And the alarm limits of a lot of our devices are too narrow that they don't allow us to program them to where they don't alarm, for the wrong reasons. Let's take a look at the evidence. This particular article, published by the American Association of Critical Care Nurses, is called Nurses' Perspectives on Clinical Alarms. And what they did is they decided to study the nurses' perspectives about alarms. And they found that there were 6 key themes that nurses felt were related to alarms and alarm fatigue. The desensitization that we spoke about earlier, panic and pathology, the accountability, who is supposed to respond to these alarms, and clinical alarm management, meaning if you have an alarm that's not working properly, who do you notify? Or if you have an alarm that you can't get to right away, who is going to be that person that's going to check on that alarm for you? This study was important because it showed that nurses are concerned about the impacts of alarm fatigue, and they recognize the importance of the nurse's role in reducing noise pollution. And nurses have a valuable insight into strategies that can reduce alarm fatigue and prevent patient errors. This next study was published by the PLOS-1 journal. It's called Insights into the Problem of Alarm Fatigue with Physiologic Monitor Devices, a comprehensive observational study of consecutive intensive care unit patients. So this study pretty much revealed that over the course of treating 436 patients in a 31-day period, there were an alarming amount of alarms, 2,558,760 unique alarms, which is quite extensive. The conclusion of this study was that the excessive number of alarms play a integral role in causing alarm fatigue, and the inappropriate settings, as well as the patient conditions, and the algorithms that are used to make those settings contributed to the alarms going off more often than they needed to. Our next study here is published by the Modern Health Journal. It's called Hospitals. Simple interventions help reduce alarm fatigue, and this one was my favorite because the interventions that took place were fairly simple, but they had significant results. So this study was conducted by a task force team that was put together at Boston Medical Center in order to find ways to prevent alarm fatigue. So they were able to gather data, and it revealed that over 67% of their alarms came from heart rate default settings. So they simply changed the settings, not only on their heart rate machines, but also on their blood pressure machines. And the way they found to keep this safe is they came up with an algorithm or parameters in which the nurse could make adjustments to the settings on these monitors. Also, before a setting could be changed, 2 registered nurses had to review the patient's history, medical record, and agree that changing those settings were appropriate. So, for example, they went from having parameters at a high of 120 and a low of 50 to a high of 130 and a low of 45. The nurses who were signed off on changing these alarm parameters also had to take a heart rate knowledge test and pass with at least 90%. So the results of the study showed that the number of audible cardiac alarms plummeted by 89% from nearly 90,000 down to 10,000, which was pretty amazing. So based upon the evidence that we've reviewed, what can we do to solve the problem of alarm fatigue? The first thing is to educate. We need to make sure that our patients and their families understand the importance of reporting alarms and not silencing them. I know we've all had that patient who got extremely tired of hearing the IV pump beep and decided to silence it themselves. So we want to make sure that all of the patients and families are aware that they are not allowed to do that, and to educate them on why. We also need to verify that all staff members who use alarm devices are properly trained to manage them, to recognize the reason why the alarm is going off, how to manage if an alarm is not properly functioning, and what to do at that point to get it fixed and out of use. The AHRQ has some recommendations, and what they recommend is that we customize the settings based on each patient. So rather than basing the settings on the unit or the organization, we're going to base our alarm settings on our patient. So for example, the heart rate or the oxygen sensor could vary from patient to patient. If you have a COPD patient, you may not want to keep their oxygen level as high as a patient that's recovering from respiratory failure or something of that nature. We want to do routine checks on our equipment with the telemetry monitors. We want to do routine electrode changes and battery changes. Let's try not to wait for those batteries to die before we change them. Each unit or each organization should come up with methods or schedules in which to get those batteries changed before they start to die. And never silence alarms. I can't say that enough. Throughout the studies that I've read with alarm fatigue, the silencing of alarms, as we saw in our case study, is one of the biggest reasons that have led to fatalities. We can also designate personnel to respond to certain alarms. So certain nurses or certain groups of people can be responsible for checking to see why certain alarms are going off and notifying the right person. We talked about the routine maintenance, and only allowing the high-level alerts to be interruptive on our alarm. So when we set parameters, we can maybe set the volumes to where they get higher as the significance of the alarm grows or something of that nature. I want to close by saying that it takes a team to provide excellent care and to keep our patients safe. So let's all reach in and give a hand in avoiding alarm fatigue and taking care of those we love. Thank you for watching. Have a good evening.